I'm very happy to be here, and I'm very happy that there are still people left in the audience. So I'm just going to start with the story. We have two elderly people here. One is, I think all of you see her, and she's a symbol of active aging, but all can't be actively aging, and you have women who are, men and women who are less fortunate, and endocrine disorders are the ones which can be making quite a lot disabled, and they may not even know about it, because many of the endocrine syndromes like diabetes and thyroid disorders, they present with symptoms of aging, and people will just think, especially the elderly people will think that they are growing old, so they are feeling weak. I myself, when I was 50, I was feeling extremely weak. I was thinking that my power, strength has come down, and when I just went and had a checkup, I learned that I have hypothyroidism, and that was the cause for my weakness, and not just because I hit 50. So when it can happen to a doctor like me, I'm sure it may be happening to many senior citizens. So in the next 10 minutes, I'm going to talk about diabetes in the elderly and issues and guidelines, thyroid dysfunction in the elderly, and adrenal insufficiency in the elderly. Due to lack of time, I'm not going to describe or discuss the entire endocrinology here. When we talk about diabetes, 1 in 5 older person is a diabetic, and 50% of them are underdiagnosed, mainly because they don't check, or even when they check, it is missed, because we always do a fasting plasma glucose, and in the elderly, fasting plasma glucose may be normal for quite some time. It is the post-food glucose which rises, and we never check it often. And many of the symptoms can be mistaken for signs of normal aging. That's why diabetes is missed. And when we really diagnose diabetes, it's a shock for everybody. I have recently had a couple. The husband was coming to me sincerely for blood sugar testing, and all the tests that I advised he was doing, he was 80 plus, and he brought his wife one day with all geriatric syndrome, and we checked her sugar, and her sugars were in 400s, and he couldn't believe that she can have, because he thought that he has checked some 2-3 years ago, and she didn't appear to be having diabetes. So that's a thing. When we talk about diabetes in the elderly, we have some diabetes related peculiarities and geriatric syndrome related peculiarities in the elderly with diabetics. So diabetic patients have many of the comorbid conditions. They have, of course, comorbidity galore. They have high blood pressure. They are at risk of stroke. They are at risk of heart disease. So cardiac failure is much more common, and they are more prone for premature deaths compared to non-diabetic elderly. They have a low GFR, that means kidney function is low, and they have a higher risk of hypoglycemia, the low sugar. And diabetic elderly persons also suffer from geriatric syndrome. They are on multiple drugs, that is polypharmacy, because of the comorbidity. They have incontinence either because of UTI or diabetes related because of polyuria. They fall frequently and injure themselves because of neuropathy. They have more pains because of the joint problems are much more common, and nerve problems are common, and they are depressed, and they have higher rate of cognitive impairment because of multiple cardiovascular diseases. So, but good news is diabetes is better controlled. Once you diagnose, it's better controlled in diabetics. They need smaller doses of drugs. They generally adhere to lifestyle better than the younger ones. They are much more compliant with the drug, that is the active elderly ones, and they have time for exercise, yoga, spirituality, and their stress levels are lower. That is, I'm talking about somebody like this young lady who's looking absolutely healthy and happy. But all are not so fortunate. So when we give guidelines for control of diabetes, we split into two groups. The one which is functionally and cognitively intact, and who have very good life expectancy. We just give them the standard of care. I think I've been hearing previous speakers who say the same thing. So they should be treated as younger people, and nothing should be denied, and they should be treated aggressively. The others we have to individualize, and we have to avoid their symptoms. We should prevent them from going into low sugar and getting the shock of their lives, or just becoming unconscious because of low sugar, and we should not also allow them to have high sugars and symptoms associated with that, that is polyuria, dehydration, unconsciousness, etc. We need to balance everything. Coming to management of cardiovascular risk factors, it again depends on the life expectancy. If somebody is 90, I don't think we need to go and aggressively control the high blood pressure or make them more miserable with the drugs. And so we need to really see the life expectancy of the person and the benefit that you are going to get. So if you control blood pressure today, if you control cholesterol today, you will prevent a stroke 10 years later and a heart disease 10 years later. So we consider life expectancy and then use these drugs. However, screening for complications that lead to functional impairment, that means retinopathy, loss of vision, neuropathy, loss of balance, kidney disease, etc., we need to really screen them for these complications, because if they develop these complications, they will be functionally impaired. And all diabetics must undergo comprehensive geriatric assessment, because geriatrics related problems are much more in the diabetic population. Coming to which drug and what dose? Of course, go slow, go low. That is the mantra of pharmacology of elderly people. So we always start with a small dose and move up. When we come to sulfonylureas, glycoside and glipizide are preferable because they are not metabolized by the kidneys. So their levels are not altered. Metformin dose again has to be adjusted according to the kidney function. Pioglitazone, it has been a question and now out of our prescription, but even then it should not be given to elders because it may produce cardiac failure. DPP-4 inhibitors are new drugs that have come into the market in a big way. They are very expensive, but now we are getting reports of congestive cardiac failure. Again, they may become a question mark. Insulin is the next option, and we have to start with a very small dose and then build it up. Dose needed by the elderly is usually 10 to 20% less compared to the younger people. Always when we prescribe insulin, check for compliance, vision, because of poor vision they may not take the adequate dose of insulin or they may overdose themselves. Injection technique has to be checked. Which I just had an 85-year-old man who came back with a broken needle inside his thigh because he had just used little more force and the needle had broken. So all these things happen. So look at the site, look at the shaky hands, whether they are able to inject it themselves, and also look at the cognitive function because they may forget and re-inject and come with hypoglycemia. Coming to the next common disorder, thyroid disorders are very common in the elderly. Thyroid anatomy and physiology change with age, and hypothyroidism is much more common, and hyperthyroidism, that is increased thyroid hormones, is less common. Thyroid tumors also increase with age. Again, symptoms of hypothyroidism, just as I described myself, you may mistake it for aging and may not test. Lethargy, constipation, aches and pains, cognitive decline, depression, muscle weakness, they can all be perceived as aging. So we all elderly persons must get a TSH test. That alone is sufficient as a screening test. If TSH is in the range of 5 to 10, we call it a subclinical hypothyroidism. Only those people should get a free thyroxine tested. If free thyroxine is low, they have to be treated as hypothyroidism. But those with normal free T4 and subclinical hypothyroidism, although it may lead to dyslipidemia, there is no evidence that elderly with subclinical hypothyroidism, if they are treated, they are going to have lesser cardiovascular risk. So the treatment is optional, it is still controversial. So goals of the therapy of hypothyroidism is to prevent progression to myxedema and relieve symptoms. So again, go slow with the thyroxine supplement because higher dose may precipitate ischemic occultic ischemic heart disease may become overt and they may have angina and chest pain and even myocardial infarction. So start with a small dose of 12.5 microgram and build it up over 4 to 6 weeks. Coming to the next condition, that is thyrotoxicosis. This is also often missed because they present atypically. Normally thyrotoxicosis presents with adrenergic overactivity, loss of weight, increased appetite, but elderly will present the reverse way. They will put on weight, they'll have depression and they will have less appetite. So we miss it. Similarly, they may just present with cardiac symptoms, that is cardiac failure, which is refractory to treatment, and they may just present with muscle weakness or bony pains because of osteoporosis. Again, they respond very well to treatment, and radioactive iodine therapy is the best treatment that's available. But for those where it is not accessible because of cost, or the center is too far off for the elderly person to go, the tablets, that is neomercazole, can be used, and a small dose of thyroxine can be added to maintain them on remission for a long time, and that we have found to be quite good for the elderly people.
Dr. Prabha, you got 2 minutes more.
Yeah. So the last chapter is adrenal insufficiency. Elderly people are at increased risk of suppression of HPA axis. Those with topical users of adrenaline, that the adrenocorticoid hormones, that is asthma sufferers, or people with skin diseases who use topical steroids, they are at very high risk. But of late, we have found out that critically ill patients, elderly patients, and frail elderly people, they also have a suppressed HPA axis. So 40 to 85% of critically ill will have some kind of HPA axis suppression, and they may need steroids during the crisis. And a study done by Dr. Medha Rao from Ramaya, she has shown that in frail elderly people, 75% had suppressed HPA axis compared to the non-frail, where it was only 20%. So it could be that adrenal hormone deficiency itself could be responsible for frailty syndrome, and supplementation may really help these elderly people. So always screen frail elderly people for adrenal hormone insufficiency, because it's a totally curable and treatable disease. So what have I done for endocrine disorders? I have got a program of prevention of diabetes and diabetic elderly people, where I have got a daycare center where around 550 members have enrolled themselves for an exercise program. Some have diabetes, some don't have diabetes. They want to prevent diabetes. So they come to the center practically every day. They also participate in a group exercise every day, and they've been doing it for the last 12 years. Quite a big number of them have been coming to the center every day, whereas others have learned the exercise and they do the exercise at home. It's a combination of balance, strength training, and flexibility exercise that they're doing, which lasts for about 1 hour. And the results have been fantastic. Diabetes progression has got arrested. Those who joined the program, their diabetes never progressed. We have had a couple of them who have reversed diabetes. People who have been on 2 medications have been off medications. Complications, they have not developed, no new complications, and we have done their heart rate variability, it has really improved. So they have grown younger by joining this exercise program. So you can see some of them here, and some of them have become younger and they are dancing also. Many of these are grandmothers who are dancing here. And we have also used yoga as exercise, and we have here senior citizens group belonging to a home for the aged who participated in a yoga program and who continue to do yoga here, and a group in our other campus in Bijay, where we showed that yoga, diaphragmatic breathing, and antioxidant rich diet reduces oxidative stress and inflammation. We are on the lookout for a single drug for reduction of oxidative stress, which is the root cause of all the chronic degenerative diseases. Here we have a very simple solution, which we don't believe unless it comes from the West. This particular paper is published in Diabetes Care, so I think now West will start accepting our yoga. I also have a patients club which is found to be very, very useful for diabetes, who come for regular education program as well as regular blood sugar testing, and they also have an annual checkup at concession rate or really low rate. That is also an intervention which is very, very successful. We also have senior citizens who are educators who go out and educate people in diabetes as well as in exercise. So to conclude, endocrine syndromes may mimic geriatric syndromes. Screen for endocrine disorders in symptomatic elderly, and elderly must screen for diabetes every 6 months and thyroid disorders annually. Adherence to exercise will prevent progression of diabetes. Frail individuals, critically ill elderly, and those with symptoms and on long-term steroid use must be screened for adrenal insufficiency. So thank you. This is our motto: arise, awake and walk and stop not till the goals of your blood pressure, cholesterol, BP and weight is reached. That is the, yes? It is in Mangalore, Kasturba Medical College, Mangalore, and we have set several such centers. Mangalore, I am not sure whether, but I think Dr. Radha Murthy's center has got a daycare center, that is Nightingale's Trust. Actually, based on them only, we started the daycare center where senior citizens come regularly and exercise. In Mangalore, we have got now 5 centers, and this year we are starting 4 more centers, because if it is closer to their house, they are more likely to use this center, and it's become a real rejuvenation center. I see them growing younger every year, and I am waiting to be 60 so that I can be a member and attend their program regularly.
Thank you, Dr. Prabha. Indeed, it was great work and contribution to what you're doing. I'm sure you're going to change M into B now. You've got to make more centers in Bangalore to make people aware and get them into healthy competition to become healthier senior citizens in Bangalore as well. As one of our persons in the audience asked, I think it's a great demand, and I think since the Nightingale Center has initiated this move, I think the demand for such a thing would happen in Bangalore with your guidance. Thank you.
A round of applause for Dr. Prabha for sharing her time with us this evening. Thank you. And a token of our love and appreciation, ma'am.